webinars are made possible thanks to generous donor support. If you'd like to contribute, please visit our website, autism.org.
Now, before we get started, I'll introduce our speaker. Dr. Gregory Wallace is trained as a developmental neuropsychologist with extensive experience working with individuals with autism across the lifespan, and currently he is an associate professor of speech, language, and hearing sciences at the George Washington University in Washington, D.C. Much of his research uses neuropsychological and neuroimaging techniques to elucidate the etiology, developmental course, and long-term outcome of autism and other neurodevelopmental disorders. This research has resulted in the publication of more than 115 peer-reviewed manuscripts. You can type your questions into the questions section now, and throughout the talk, he'll answer as many as he can at the end. Now I'll turn it over to Dr. Wallace.
Thank you, Denise. So again, my name is Greg Wallace. I'm currently an associate professor at the George Washington University in Washington, D.C. And today I'll be talking about middle and older adulthood and autism, particularly brain and behavioral outcomes. My talk is organized as follows. I'll provide a very short background on aging and autism. Then I'll focus on three different areas of outcome: health, brain and cognition, and finally, quality of life. Let's begin by focusing on some basic background information on aging and autism. Children were first diagnosed with autism in the 1940s. Thus, they have only recently, or relatively recently, reached old age. Opportunities to study aging and autism have therefore been very limited. Accordingly, the knowledge base on aging and autism is very small. Recent CDC-based estimates suggest that about 2.2% of adults in the United States are autistic, equating to about 7.28 million adults. This includes about 1.2 million adults who are 65 years of age or older. This is a very important yet neglected age range for study in autism, particularly given the number of adults who are affected and the rapidly aging US population. In fact, it's projected that by 2034, for the first time, the US population will have more adults who are 65 years of age or older than children under 18 years of age. So when discussing autism in adulthood, there are important factors that should be highlighted. Particularly relevant here are the challenges in diagnosing autism during adulthood. In fact, many adults with autism are undiagnosed due primarily to changes in diagnostic criteria over time. The goalposts, if you will, for who can qualify for autism-related diagnoses have changed over time, particularly from DSM-3R to DSM-4 with the introduction of Asperger's syndrome. For those that don't know, DSM, the Diagnostic and Statistical Manual of Mental Disorders, is the way that it provides the diagnostic criteria for mental disorders such as autism spectrum disorder. Diagnosing autism during middle and older adulthood is also very challenging due to reliance on early developmental history and the possible development of later compensatory skills. Given the age of the potential autistic adult, acquiring accurate developmental assessment is potentially challenging given that some parents will be deceased, living parents will be older, and there will be an enormous amount of time elapsed since early childhood. Exacerbating this are the compensatory skills that autistic individuals can develop to more easily fit in or pass in the neurotypical world. These compensatory skills, while potentially advantageous, though often highly taxing, can complicate delineation of autistic symptoms during clinical assessment. Finally, there's another added layer of complexity when diagnosing women with autism due to their elevated likelihood of engaging in so-called camouflaging behaviors, another form of compensation, as well as historic systemic bias against diagnosing females with autism, as well as other factors. So next, I'm going to review evidence on health outcomes in autism during middle and older adulthood with a slight segue into some of our own work in this area. Okay, because it's the largest study of its kind in the United States, the work of Hand and colleagues will be the primary evidence I present on poor health outcomes in autism during older adulthood. This study examined Medicare data from 4,685 autistic adults who were 65 years and older and compared them to a control group that was 10 times larger and included 46,850 participants. Numerous medical and psychiatric or mental health conditions were found much more commonly among older autistic adults than among control adults. These included epilepsy, gastrointestinal conditions, hypertension, osteoporosis, and injuries, such as fractures, as well as ADHD, anxiety and mood disorders, and suicidality. But I just want to be clear, I'm just highlighting these. There were others that appeared much more commonly in autism than in the control participants. I want to highlight one co-occurring condition in particular, which is Parkinson's disease. Hand and colleagues in this Medicare data set found a 6-fold increase in Parkinson's disease diagnoses among older adults with autism versus controls. This discrepancy was even larger for autistic females than neurotypical females. Parkinson's disease is one form of Parkinsonism. Parkinsonism is an array of motor symptoms akin to those observed in Parkinson's disease, including tremors, slowness in movement, and stiffness. The Hand et al. Medicare study is not the first to implicate elevated rates of Parkinsonism in autism. Starkstein and colleagues in 2015 examined Parkinsonism in 2 samples of adults with autism, one in the United States and one in Australia, using the gold standard neurological assessment of Parkinsonism, the Unified Parkinson's Disease Rating Scale. In one sample, about 16% of those who were 49 years of age and older with autism met criteria for Parkinsonism, whether or not they were also taking antipsychotics or neuroleptics at the time. In the other sample, an even higher rate of 25 to 32% of 40-plus-year-olds with autism met criteria for Parkinsonism, whether or not they were also taking antipsychotics or neuroleptics. Antipsychotic or neuroleptic usage is really important here because they can actually induce a Parkinsonism type syndrome. Unfortunately, neither the Hand Medicare study nor the Starkstein et al. Study could adequately disentangle antipsychotic-induced Parkinsonism from idiopathic forms in their studies. Therefore, we sought to examine this further. So we collected self-report data via Simon's Powering Autism Research and Knowledge, SPARK. So we collected these self-report data via SPARK on independent adults. Independent adults are those who could consent for themselves, who were ages 40 and older with autism. Our sample was 409 autistic adults. And we wanted to examine not only Parkinsonism rates, but also whether Parkinsonism itself is linked to other outcomes in these adults. Participants taking antipsychotics, which was 52 individuals. Those who did not report medication usage, thus we weren't sure whether or not they were taking antipsychotics at the time. That was 53 individuals. Those who were self-diagnosed, 3 individuals. And those with conditions that could impact Parkinsonism ratings, things like cerebral palsy, Parkinson's disease itself, stroke, TB or traumatic brain injury. This was 30 individuals. They were all excluded from the analyses that I'm going to present below. This resulted in a sample of 279 autistic adults, ranging in age from 40 to 83 years, with an average age of 52, and more than half the sample was female based on their sex assigned at birth. In order to evaluate features of Parkinsonism in the sample, we utilized the 6-item Parkinsonism Screening Questionnaire, or PSQ, as I'll keep referring to it from now on. The questions on the PSQ focus on, and you can see all the questions here, all 6 of them, stiffness in your legs, the presence of tremors, difficulty buttoning or dressing, a lack of arm swing when walking, your feet being stuck to the floor, and becoming slower in your daily activities. So what I've done here is I'm presenting the item level data from the PSQ, and it's not just in the autistic group, which is blue, but I've added 2 other groups here. There are control adults in green, and adults with Parkinson's disease in this sort of orange sherbet type color. These 2 groups, the Parkinson's disease and control groups, the data here were derived from the original PSQ study by Farish-Tenajad and colleagues in 2014 that validated the PSQ itself. As you can see from the data here, the autistic group in blue is self-reporting much greater frequency of Parkinsonism features than the control group in green, and that's for all of the items. However, it is important to point out that the endorsement rate for these Parkinsonism features in the autistic group clearly does not reach the level of the Parkinson's disease group. So the blue bars are lower than the orange bars, in other words, but the blue bars are still much greater than the green bars. So the PSQ employs an optimized weighting score to maximally distinguish individuals with Parkinson's disease from neurotypical controls. Applying this cutoff score in the autistic sample results in 31% of these individuals screening positive for Parkinsonism, which is quite high, or is very high. And you have to keep in mind that that's after removing individuals who have other conditions that could either elevate Parkinsonism rates or even be associated with a different form of Parkinsonism, i.e. that antipsychotic-induced Parkinsonism. So the first thing we've done is shown elevated rates of Parkinsonism in autism, pretty comparable to those reported by Starkstein and colleagues in their in-person study utilizing neurological exams. So taking this a step further, we sought to examine possible differences in real-world functioning for the autistic participants who screened positive for Parkinsonism, so I'm going to call that the PSQ plus group, versus those who screened negative. I'm going to call that the PSQ minus group. In order to do this, all participants completed not only the PSQ, but also a battery of other self-report questionnaires, assessing, and you can see the list here, subjective quality of life, everyday memory functioning, daily living skills, and executive functioning. Before examining these possible real-world differences, we also examined potential demographic differences between the PSQ plus and the PSQ minus groups. While the groups did not differ in age, they did differ in sex ratio. The female to male proportion was significantly higher in the PSQ plus group than in the PSQ minus group. And as you might recall, the Hand et al. Medicare study also demonstrated an exacerbation of the increased Parkinsonism rates in autistic females. I'll also note here that because age and sex could impact self-ratings of everyday functioning, they were included in all of the analyses I'm about to present as covariates. So for the first comparison, what we found was that subjective quality of life in the areas of physical health, the environment, and autism-specific needs were all lower in the PSQ plus compared to the PSQ minus group. So in other words, Parkinsonism negatively impacts subjective quality of life across all of these areas in the context of autism. Similarly, there were clear and robust effects of Parkinsonism on memory functioning in autism. The PSQ minus group reported better prospective and retrospective memory than the PSQ plus group. So in this case, you're seeing the green bar, meaning the screen negative, Parkinsonism screen negative group is scoring or reporting better memory functioning than the screen positive, the Parkinsonism screen positive group. In terms of executive functioning, the subdomain we're talking about here is flexibility. There was both a main effect of Parkinsonism group and an interaction between Parkinsonism group and scale on the flexibility scale revised. All of that's to say that they were both of these effects were driven by the fact that the PSQ plus group reported more inflexibility around routines and rituals in their daily lives than the PSQ minus group. Finally, and interestingly, the Parkinsonism groups did not differ in their daily skills ratings, nor did they differ in their ratings of their inhibitory control or emotion regulation. In other words, autistic individuals who screened positive or negative for Parkinsonism did not differ in how well they completed daily living skills, including things like grooming, toileting, etc., nor in their ability to inhibit a prepotent response in everyday life or to regulate their emotions. So taken together, our data, along with the previously published studies, suggest that Parkinsonism is fairly common among middle and older age adults with autism. It's possible this heightened prevalence of Parkinsonism in autism is exacerbated for women with autism. And we show here for the first time that these Parkinsonian motor symptoms are associated with overall poorer outcomes in autism during middle and older adulthood, including decreased subjective quality of life, decreased memory functioning, and greater behavioral inflexibility. Now I'm going to turn to other brain-based and cognitive outcomes that have been examined among middle and older adults with autism. So one way this has been framed in the literature was by Lever and Gertz in 2016. And it was as follows. They wanted to ask the question whether brain and or cognitive aging trajectories in autism, how are they the same or different from that found in neurotypical controls? Or I should say in neurotypical aging. So, does cognitive aging, does brain aging follow a trajectory that would be considered parallel? So this is here on the left, where the neurotypical controls are in blue and the autistic group is in sort of this burgundy color. Although the autistic group is below the neurotypical group, suggesting a difference in performance, they're both declining across age at pretty comparable rates. So that's the parallel trajectory. The middle one is called double jeopardy. And what that means is that the autistic group is not only performing worse than the neurotypical group, but they're actually declining faster. So they have a steeper downward slope with increased age than the neurotypical group. And then finally, another possibility is sort of this safeguarding trajectory, where the autistic group in burgundy actually has a more shallow slope. So they're not declining as fast as the neurotypical group in blue. Okay, so this is not meant to insult anyone's intelligence. I'm just trying to give a very, very simple introduction to start so that when I start saying certain words, everybody's on the same page. So just in case some of you are not familiar, I'm providing this brief introduction to some brain development basics based on magnetic, I don't know what just happened there, based on magnetic resonance imaging or MRI. So as I'm sure most of you know, we examine macro level brain differences based on tissue type, gray matter versus white matter. On a T1 weighted MRI scan, such as the one pictured here, gray matter is gray and white matter is white. And the gray matter is actually part of this cortical ribbon that envelops the white matter. So the white matter is underneath, and the gray matter is on the outside, and it's sort of this ribbon surrounding the entire cortex. And I'm just using this as an illustration. So one gray matter structure, or metric of gray matter is cortical thickness. So I just wanted to illustrate how that's measured so you have a sense of how that's done with MRI. On the left is the MRI scan you just saw. On the right is a blown up representation of a gyrus. So sort of the hills, that's the gyrus, the valleys, that's the sulcus, or I should say gyri and sulci. Cortical thickness represents the distance between the boundary of the gray and white matter, which is depicted in yellow here, and the peel surface depicted in red. So that distance, just simply that distance between the yellow and the red lines in the right-hand picture, that's cortical thickness. Brain imaging and analysis software can measure cortical thickness at tens to hundreds of thousands of points across the cortex. These points, they're called vertices or a vertex. They're depicted here with these sort of purple dots. And then each cortical thickness value is represented by a green arrow. So that literally is how we are deriving cortical thickness across the entire cortex. And I'm sorry about these slides. They must have some timing built in that I didn't realize. Hopefully that doesn't keep up. All right, so that's looking at one metric of gray matter structure. What about gray matter function? Functional MRI or fMRI measures the hemodynamic or blood flow response in gray matter. And sometimes this is to the presentation of a stimulus, and sometimes it's what's called at rest, meaning the participant is lying in the MRI scanner and not doing anything in particular. And sometimes the experimenters will even say things like, clear your mind and think of nothing in particular when they're looking at resting state MRI or fMRI. All right, so here's an example of a task-based fMRI paradigm. So here on the left in this image, they have a visual image that's presented for 1 second, and it's these kind of like a circular grid, if you will, if that's not an oxymoron. So this visual image is presented to the participant for 1 second, and then we use fMRI to measure blood flow to different parts of the brain. And this hemodynamic response is an index of brain activity. Because what we just showed, I'll go back a slide, is this visual image. What we find here is that in the very back of the brain, the occipital lobe, also known as visual cortex, we find this hemodynamic response where it's this curve depicted here as this red curve that occurs several seconds after the presentation of the image itself. So this is all we're doing with fMRI, and it's quite complicated, but boiling it down, this is all we're doing. We're measuring this spike in blood flow in different parts of the brain to the presentation of a stimulus or when you are, quote unquote, at rest. Now, we also, you might have heard, and we might talk about functional connectivity. Functional connectivity is utilizing this hemodynamic response, these curves, and seeing how they are coupled or similar to one another in different parts of the brain. So the more similar these curves are to one another, the more correlated they are, therefore, the greater the connectivity between different parts of the brain. In other words, different parts of the brain are working in sync with one another in theory when we talk about functional connectivity. That's probably a poor oversimplification, but I wanted to give you a sense of what we're talking about. Okay, now let's move from gray matter to white matter. The most widely used method for assessing white matter measures the directional diffusion of water along fiber bundles. And this, in turn, reveals structural connectivity between brain regions. This diffusion MRI enables the creation of three-dimensional images of fiber tracks as depicted here on the right-hand side, right? So on the left is old school drawing of what white matter is supposed to look like. And then on the right is the kinds of images we can get with diffusion MRI. And you can see they go in all kinds of directions, these fiber tracks, and because they can go in all kinds of directions, it is very complex to analyze this data. Okay, now, one more contextual slide, and I wanted to keep it short and sweet. In middle and older adulthood, and this is in neurotypical aging, there's a gradual and slowly accelerated loss of both gray and white matter tissue as age increases. This is depicted here for both gray matter and white matter volume loss across adult development with the image at the bottom. Okay. Now, what have we learned about brain-based outcomes during middle and older adulthood and autism? Well, the first thing, unfortunately, is overall, it's important to point out that there is very limited information on brain structure and function in autism during middle and older adulthood. Secondly, the findings that have emerged have been somewhat mixed in most cases, or just super limited in others. So let's start with gray matter structure. So for gray matter structure, one study found decreased cortical folding in autism. So I showed you the gyrus and the sulcus. So it's actually a degree of that folding relative to the size of the brain. So one study found decreased cortical folding in autism, while another did not. Two studies completed to date, which are the two bullets under gray matter structure, failed to find differences in cortical thickness or surface area in autism. And finally, one study suggests decreased volumes of the hippocampus during middle adulthood in autism. In the hippocampus, the picture here on the right of the slide, the structure there in red, and this is the subcortex. Mostly we've been talking about the cortex, but in the subcortex, that red structure there has been found to be smaller during middle adulthood in autism. Turning to gray matter function, there have been 3 fMRI studies, all of which have suggested decreased connectivity between brain regions. 2 of these fMRI studies were task-based. So they were during the completion of one was a working memory task and one was a sensory motor task. And then one study found decreased connectivity when the participants were at rest. In other words, not asleep, but not doing a task while in the scanner. Finally, one study of white matter structure has demonstrated increased radial and mean diffusivity in autism compared to neurotypical controls in adulthood. This is suggestive of reduced structural connectivity in autism compared to controls during this developmental period. So turning back to the question of brain aging trajectories, in one cohort of adults, this was a Dutch study, there were similar age relationships with cortical thickness for both autistic and neurotypical adults, while there was a greater decrement in white matter microstructure among autistic than neurotypical individuals. Excuse me. So in other words, for cortical thickness, this is a cross-sectional study, keep that in mind. There was an age-related loss of tissue, cortical thinning, I'll put that in air quotes. There was comparable cortical thinning in the autistic and the neurotypical adults, but there was a greater loss or demyelination of white matter in the autistic than in neurotypical individuals. Now, having said that, I've already semi-alluded to this here. It is critically important to point out that the real test for trajectory differences in autism requires longitudinal data. Unfortunately, no longitudinal studies of brain development have been completed during middle and older adulthood in autism. Okay. Now I'm going to turn to cognitive aging. As with neuroimaging, there's relatively scant evidence on cognitive aging in autism and its comparability to patterns observed in neurotypical development. Thus far, as with brain development, the results have been mixed. The most consistent finding here is that older autistic adults report subjective executive functioning challenges in everyday life, particularly in the area of behavioral inflexibility. This finding parallels self-report results found during adolescence and young adulthood in autism. In other words, across the lifespan, people with autism are reporting that they have everyday executive functioning challenges pretty much across the board, including areas like planning, working memory, but particularly for behavioral inflexibility. Now, based on several cross-sectional studies in the United States, UK, and the Netherlands, there's evidence for parallel, double jeopardy, and safeguarding patterns in cognitive aging and autism, vis-a-vis patterns found in neurotypical adults. However, once again, none of these studies are longitudinal. Therefore, the question of what trajectory best characterizes cognitive aging in autism has yet to be answered. So taken together, there is evidence, albeit limited, for both parallel and divergent brain and cognitive aging in autism. But because there are no longitudinal studies completed on brain and cognitive aging in autism, this remains an open question, to say the least. Okay, now turning to the last section of the talk, I'll review quality of life outcomes examined in middle and older adulthood and autism to date. So in 2012, in the UK, the National Autistic Society surveyed 355 autistic adults who were 45 years of age or older. The results were startling. 2/3 of participants had not had their needs assessed since they were 18. Most of these adults relied on family for various forms of support. And when support was lacking, isolation ensued. 1/3 of the participants reported going weeks without speaking to anyone outside of their household. Subsequent qualitative studies that attempt to tap into the lived experience of autism reported similar themes and extended them. For example, although an autism diagnosis was beneficial in contextualizing their difficulties and increasing their sense of agency for those who were diagnosed late, loneliness was a persistent issue. Additionally, when asked about the concept of aging well and how it might be applied to autism during adulthood, autistic adults reported the need to include greater accommodations and to increase acceptance in order to strive for this goal. Turning to quantitative studies, Mason and colleagues found that among 55-plus-year-old autistic adults, there was a divergence in objective versus subjective quality of life. Objective measures of quality of life include things like, are you employed or not? Is your job full-time or part-time? Does your job require supports or is it independent? This is, whereas subjective quality of life is things like life satisfaction or your happiness. So this is critically important to think about because many objective metrics of quality of life are societally determined or driven. So for example, in the not too distant past, being single versus married was a measure of objective quality of life. And that, as you could imagine, has some serious bias built in, as if everyone's goal is to be married, for example. So these objective measures at times may not reflect an individual's own life goals or neatly predict their happiness. So it's really important to assess both objective and subjective quality of life in autism. Okay, turning to the second bullet on the slide, perhaps unsurprisingly, co-occurring mental health conditions, particularly depression and anxiety, have been shown to detrimentally impact both objective and subjective quality of life in autism. Given that both depression and anxiety are their co-occurrence is highly elevated in autism compared to general population base rates, it's imperative to attempt to alleviate and manage these symptoms. So there are many possible contributors to subjective quality of life in autism. We recently examined links between various forms of social support and subjective quality of life among middle and older age adults with autism, ages 40 to 83 years. Even after controlling for numerous factors, subjective social support in particular was linked with a plethora of indices of subjective quality of life. While social interaction with support was linked with better psychological quality of life, and instrumental support was associated with better autism-specific quality of life. So, in spite of emerging evidence substantial problems and pitfalls remain in the quest to better understand aging and autism. First, cohort issues are substantial. Diagnostic criteria for autism-related diagnoses have changed over time from DSM-3, 3R to DSM-4, 4TR to DSM-5. This includes the aforementioned introduction of Asperger's syndrome with DSM-4, for example. Accordingly, there are likely changing rates of co-occurring intellectual disability associated with autism. Children diagnosed with autism in the 1980s had co-occurring intellectual disability in about 70 to 75% of cases, whereas now, children diagnosed with autism have co-occurring intellectual disability diagnosed about a third of the time, according to CDC estimates. Additionally, living with an autism diagnosis as a child versus an adult is a completely different experience, and this can affect service provision, mental health, etc. Finally, there are massive differences in history with some older adults who are diagnosed as children having experienced things like institutionalization. Additionally, treatment histories could be considerably different across eras. Finally, what's becoming apparent across many efforts to study aging and autism is that study recruitment is challenging. And as I've suggested numerous times throughout the talk, there's a real dearth of knowledge surrounding middle and older adulthood and autism. Accordingly, one significant aging-related concern, dementia risk, is unclear in autism. Is this risk comparable to, increased, or decreased among autistic adults relative to population-based expectations? There's virtually no data on this topic. Of course, one of the complicating factors here is difficulties around assessment of and disentangling of autistic features from those linked with dementia and aging-related declines. In fact, essentially none of the standard instruments to assess dementia and cognitive decline have been validated in autism. There is work on this topic among adults with intellectual disability, particularly Down syndrome. Thus, we don't need to necessarily start from ground zero here. So, in summary, research on aging and autism is truly in its infancy. Sorry about the sloppy wordplay there. But considerable challenges remain. Evidence to date suggests that co-occurring medical and psychiatric conditions are common, and many of these detrimentally impact quality of life in autism. There are highly suggestive links between autism and Parkinsonism that require further examination. Longitudinal studies of brain, cognition, and behavior are needed in order to map trajectories of decline and their comparability to patterns found in neurotypical development. It's really important to focus on subjective quality of life, not only objective quality of life, as markers in assessing outcome. And participatory research approaches are needed to capture the lived experience of autism and to inform a research agenda driven by the central stakeholders. So I'm going to end it there and acknowledge a postdoctoral fellow working with me, Dr. Goldie McQuaid, and Spark and all of their efforts. Thank you very much.
All right. Well, thank you, Dr. Wallace.
Thank you.
So there are a lot of questions in the QA if you want to start to look at those. For people who are listening, please feel free to continue to type questions in the Q&A section. I know there's some information in the chat as well, and I'll go through that. And Dr. Wallace, I can read you if there are questions that people have put in the chat during the talk.
Okay. So do you want me to, I'll start with the Q&A then?
That'd be great.
Okay, so the first question, I don't know which order, I think this is in the order in which they came. So the first question is, any potential correlation between Parkinsonism, Parkinson's traits, and traits diagnosis of dyspraxia? I think that's a great question. This is from Polly Cockram. And so, Polly, what I would say to that is, I mean, the answer is no idea, right? We don't know. Shocker, given what the drum I keep beating throughout the talk. But what I will say is that we do have to wonder about and be careful about, is the Parkinsonism we're observing, is it something that's actually of adult onset? Are these motoric behaviors something that have been there all along? Or is there an actual decline or onset of these symptoms during later adulthood? I think you're kind of getting to that, sort of. And I have this same question of, is there something else going on? So in other words, shocker, we need longitudinal data in order to answer questions like this. We have to understand, and we need historic data, like you're saying, in terms of understanding how dyspraxia itself might be related to Parkinsonism, potentially later in development. So the next question is, how solid is the correlation between normal aging and decreased cognitive functioning? So Sheila, you said, I noticed all the tracks in the trajectories study go downhill. So just to be clear, we're talking about group averages, and when we talk about these decreased cognitive functioning. And of course, those images that I used when I was depicting the parallel, safeguarding, and double jeopardy, those are just for illustrative purposes, right? They're not meant to reflect reality. So normal aging, decreased cognitive functioning, well, it depends on the area of cognition we're talking about. Certain components of cognition decline more greatly than others. So areas like working memory and processing speed decline quite a bit. But then other areas like your crystallized knowledge, your knowledge of facts and information, they don't necessarily decline at all as you get older. And some studies might even suggest they increase. Now, having said that, this is a group effect. This isn't meant to represent every individual by any means, because there are plenty of individuals who don't decline in these areas, but plenty who do. I hope that answers your question. So Anthony asked, did you measure electrical signals and chemical changes in your research, not only blood flow? Unfortunately, Anthony, and those, just to be clear, Anthony, those are not my studies. Those are other investigators. Those studies that I reported are all either actual tissue. So you're actually looking at MRI of brain tissue, gray matter, white matter structure, or you're looking at blood flow using fMRI. So the short answer to your question is those studies did not look at electrical signals or chemical changes. I would not be surprised if pretty soon we don't see some. I think I have seen posters at the NSAR, the big autism research conference, on EEG studies. So looking at more on the electrical signal side in aging and autism. Calvin asks how to reverse degeneration in the working memory and ASD, ADHD double diagnosis, middle-aged patients. That is, well, so autism, so here, okay, taking a step back, we actually don't even know what the co-occurrence rate of ASD and ADHD in middle age is, first of all. We have a really good sense that, ADHD co-occurrence with autism is very high in children and adolescents, but we don't have a good sense of what it is in middle age and older. So because working memory in particular is impacted by ADHD, yeah, I think you would almost maybe want to seek best evidence for treatment of ADHD in middle adulthood. That's probably where I'd start to answer that question. Anyway, I'm not sure I'm being very helpful because, again, our knowledge base is pretty limited. Calvin also asks, can combating depression and anxiety reduce or defer the onset of dementia during middle-aged adulthood? I don't think we know the answer to that, Calvin, but there is some evidence for the impact of particularly late life depression. And the one thing I didn't talk about here, but is the interaction between physical health and mental health as one gets older, not in autism, I'm just talking about in the general population, and how that actually is very problematic. So for example, if you have hypertension, that can actually impact, if it's untreated hypertension or high blood pressure, that can impact your white matter, which could then in turn impact your brain health, which could in turn impact your cognitive and mental health. So there is a lot, we have a lot to learn about autism, and since autism is at elevated risk for both the physical health side and the mental health side, the fact that both of these are occurring, they could be a double jeopardy of sorts for brain and cognitive development themselves. But we don't have good evidence to say, we just need to work on that. Someone asked, are you aware of longitudinal studies currently underway? And the answer is yes. I know of a couple of studies underway on longitudinal brain and cognitive development and autism during middle age. There's one at Arizona State with Blair Braden, and there's one in the Netherlands with Hilde Gertz. Any information on expected lifespan for people with autism? So we have some evidence for a somewhat truncated lifespan, so slightly shorter lifespan for people with autism. I don't know how good the data are in this country. I feel like there's been one decent study, but some of this is explained by, so in other words, the shortened lifespan in autism, some of it is explained by particularly co-occurring seizure disorders leading to a shortened lifespan, because seizure disorders are relatively common in autism, and the increased propensity for accidents in autism. And as someone else mentioned, there's this real interest in the social determinants of health, healthcare access, all kinds of things going on with autism. But I don't have great data to report there. I can just tell you the little bit of information I've seen as to explain the somewhat lower lifespan in autism that's been reported. Someone asked, how's the autism brain in older adults compared to younger adults and children? Well, that's very complicated because there are very dynamic changes ongoing in terms of brain development across the lifespan. But what I would say is, when I mention differences in the brain in autism in the studies I talked about, those were relative to neurotypical controls. We don't really have good data on, because you're talking about within an autism group, how does the brain differ from childhood onward into older adulthood? And the short answer is we don't have good data to answer that. And the cohort effects that I was talking about make that very complicated. So if I went and scanned right now, went and scanned 50 older adults with autism, 50 younger adults with autism, and 50 young children, you'd have to be super careful because it's almost apples to oranges. Those older adults, they might be more likely to have an intellectual disability. They might be more likely to have epilepsy, more likely to have all kinds of other co-occurring conditions because of the cohort effects associated with when they were diagnosed with autism. And I agree with what Alexander says, saying that the 2.2% of US adults have autism. The CDC estimate has some built-in assumptions, and that's right. But that's why what the CDC is trying to say here is that 2.2% of US adults have autism, but That doesn't mean 2.2% of adults are diagnosed with autism. They're just estimating the number of autistic adults that are out there. There certainly aren't that many who are diagnosed. There's a huge number that are undiagnosed, and that undiagnosed number gets larger with increasing ages. And let's see, I'm bouncing all over the place. Someone asked, are 30-minute moderate intensity aerobic exercises and resistance training, can they defer onset of dementia? I don't know about deferring the onset of dementia, but what they can do, there's definitely data demonstrating that aerobic exercise can help to offset the loss of brain tissue, particularly in areas that are associated with memory and other things, so like the hippocampus that I mentioned. Yes, that's one of the few, what would I say, robust findings of deterring sort of brain aging that's out there, is links between exercise and at least minimizing the effects of brain aging. Someone asked about the Mediterranean diet deferring onset of dementia and ASD, and I don't know. There's no evidence. I have no idea, but I think the Mediterranean diet has its own benefits in terms of long-term outcomes. So it's bouncing. I can't keep up. I don't know. Someone asked about connections between Ehlers-Danlos syndrome and autism. I know there's been a linkage established in the literature, but I don't know anything further than that in terms of current studies on the topic. Someone asked if are there brain changes in older autistic adults that cause autistic adults to get better at things, and I don't know. We don't know yet. I mean, this could possibly be that safeguarding piece, right? So there might be aspects of cognition that are almost preserved relative to expectations of decline in neurotypical development. We just don't have enough information to answer that question. Someone asked about links between autism and swallowing issues, and the problems that develop with pneumonia with invasive. I think because autism is associated with a lot of these other secondary issues, just on average, I think it is going to be a concern. And this is why the whole area of looking at the fact that autism is associated with so many other physical health conditions, that's by default going to impact these long-term adult outcomes in autism. Someone asked, do you have testing methods for nonverbal or limited verbal adults with autism? There is a bit of literature on this. I think, as always in the autism literature, it's catered more to children than adults, but there are studies examining, or I could give you information offline on that, or I could look stuff up if you want. Let's see. How is dementia measured in adults as they age and how it affects their cognition? Okay, well, that's complicated, but the short answer is it's usually through cognitive testing. And just like I talked about with the importance of longitudinal studies, when it comes to dementia, you have to establish that decline, right? So you can establish that decline based on reporting by the person or reporting by caregivers and or by cognitive testing yourself or observation yourself over time and seeing these skills deteriorate, unfortunately. Let's see. Someone asked about diagnosing adults with autism and the female phenotype, largely anecdotal, struggling to find good research. I can certainly provide information on that offline adult diagnosis and autism. It's complicated to say the least, but there are clinics around that specialize in this kind of thing. And someone mentions volunteering for studies, and that's fantastic. That's always helpful. Thank you for that. You could, if anybody's interested in participating in research, you can join the Spark, which I mentioned. If you looked up Spark, S-P-A-R-K, Autism, Simon's Powering Autism Research and Knowledge, you can volunteer there and you get informed about studies. That's where I've been doing quite a bit of my research on both young and older adults with autism. Someone asked if I'm Canadian. No, I am. I did do my PhD in the UK, though, if there was some strange wording or something that I used. Someone asked about any upcoming treatments, therapies, alleviate ASD, ADHD. And I do not know that, but there is a greater recognition of the co-occurrence of ASD and ADHD and a real focus on trying to understand treatment efficacy in those with both ASD and ADHD, whether it's on the medical or pharmaceutical side and or the psychosocial treatment side.